Good afternoon. Firstly, I would like to thank Guo副校长for having me to present my research interest and my work to my dear colleagues and potential collaborators in this campus. My background is a psychiatrist, working with patients with major depressive disorder for more than 25 years. I also lead the mind-body interface laboratory, focusing on clinical and preclinical research for more than 15 years with my colleagues Zhang Beizhen医师. Being a physician and a neuroscientist, I deeply understand the huge gap from basic research to clinical application. We really need more collaboration with translational scientists who work with patients to transform the research into patients' care. So I'm going to talk about depression and cover my previous work about omega-3 fatty acids and our recent study about inflammation. 我今天的主题要来跟大家分享一下利用 omega-3 特别是 EPA 在慢性发炎相关的忧郁症的治疗跟未来的研究方向。Major depressive disorder is a major global issue affecting 1/10 of world population, leading the cause of world disability. The advance in medicine dramatically improves the patient's care. However, as a physician, I still witness the devastating impact of this disease to the patient, to their close relations, to the society, at a daily basis because of the current treatment unmet clinical needs. For example, in the largest clinical trial of depression, the study, only 27% remitted after 14-week vigorous treatment with the first-line antidepressant treatment. And after 1 year, the 4 labels treatments with combination of choice from 10 drugs and non-drug therapy, up to 1/3 of patients still significantly ill. And despite of the ineffectiveness, most patients are still mainly treated with drugs. 75% outpatients in the United States and maybe higher in Taiwan, mainly taking medication. My research focuses on non-pharmacological therapy or mind-body interventions, starting by the inspiration of this 1998 Lancet paper showing that countries with high fish consumption to have a lower prevalence rate of depression, implying the protective effect of omega-3 fatty acid. The fact that omega-3 is important in depression comes from several lines of evidence. In addition to the epidemiological observation I just mentioned to you, in case control studies, the lower omega-3 levels had been found in depressed patients as we published the first meta-analysis in biological psychiatry in 2010. However, epidemiological surveys and case control studies don't provide causal effect relationship. The direct evidence from randomized control trial should be the gold standard. So in 2003, we published one of the first RCT to support omega-3's antidepressant effects. And in 2007, we published the first meta-analysis in Journal of Clinical Psychiatry to further support the clinical application of omega-3 fatty acid in depression. In 2012, we updated the meta-analysis in molecular psychiatry, and we found that the antidepressant effects is mainly from EPA, but not DHA. And for your information that EPA and DHA are 2 major components of omega-3 fatty acid, with EPA being more anti-inflammatory and DHA being more neuroprotective. And to our surprise, the antidepressant effects from EPA is consistently reported by several independent groups. Therefore, we started to think about personalized treatment of using omega-3, especially EPA, in inflammation-related depression. The inflammation theory of depression is now one of the important and promising theories for depression. For example, clinical depressed patients manifest higher levels of inflammatory cytokines, and second, anti-inflammatory effects seems to be the common mechanism of all kinds of antidepressant treatments, and third, in the experimental model of human and animal, the pro-inflammatory cytokine can induce sickness behaviors and depression, including the most powerful supportive human model of interferon alpha-induced depression. And how did stress-immune interactions actually lead to depression? As you can see in the left figure, infection and injury leads to inflammation and cytokine production, and then affect brain function through three pathways, including first, the leaky regions of the BBB, the activation of autonomic nervous systems, and the direct microglia activation via specific hormone and the neural routes. In fact, the idea of using omega-3 inflammation-related depression has been supported in a series of our previous studies about interferon alpha-induced depression. Since 2006, we have been working with patients receiving interferon alpha therapy when it was still the only standard treatment for chronic hepatitis C viral infection. As the incidence of interferon alpha-induced depression is very high, some clinicians consider drug prevention. However, it's not clinically applicable to expose patients, especially most of the patients who don't develop depression, to unnecessary medications. In 2010, we published the lower omega-3 blood levels and specific phospholipase A2 and COX-2 genotype to be a risk for interferon alpha-induced depression. We saw that omega-3 is well tolerated as compared to drug. Therefore, we conducted the first placebo-controlled double-blind clinical trial to test the prevention effect of omega-3 EPA in interferon alpha-induced depression. There you can see in the right that EPA is the most effective to reduce the risk, while both EPA and DHA delayed the onset time of depression. Our study not only provides the important clinical possibility to change the treatment and prevention, but also confirms the notion that anti-inflammatory strategies are effective antidepressants in the context of depression associated with inflammation. We also want to identify inflammation subgroup not only by biomarkers but also by clinical phenotypes. So we investigated the depressed patients in two groups, including major depressive disorder and interferon alpha-induced depression, presenting physical comorbidity and somatic symptoms. And we found that lower omega-3 blood levels and higher inflammatory markers are associated with somatic symptoms in depression. This series of research linking omega-3, inflammation, and somatic symptoms are beautifully done by my colleagues Jen, Dr. Zhang. We also investigated patients with cardiovascular diseases with comorbidity of depression as a subtype, and we found that cardiovascular disease patients with depression had lower levels of omega-3 and omega-3 to omega-6 ratio as compared to non-depressed patients. We are also interested in how EPA and DHA may act differently in brains and in bodies. So we measure gene expressions and brain activation in depressed patients receiving EPA versus DHA. So in this study, we apply genomic studies. We compare gene expression on messenger RNA levels in 27 major depressive disorder before and after 12-week EPA and DHA treatment in randomized control trial. We found that both EPA and DHA decreased COX-2 gene expression, but only EPA increased the glycosylic phospholipase A2 enzyme. In this study, we try to investigate why EPA is more effective than DHA in brain imaging studies. So we compare brain response to emotional stimuli in 24 major depressive disorder patients before and after 12-week EPA and DHA treatment. And we found that EPA, but not DHA, increased dorsolateral prefrontal cortex and ventrolateral prefrontal cortex activity when processing positive emotion. In addition, the increased activity in ventrolateral dorsal prefrontal cortex was significantly associated with the improvement of symptoms, and the increased activity in dorsolateral prefrontal cortex also revealed similar trend. To summarize, it seems that EPA and DHA have different actions in peripheral tissue of gene expressions as well as in brain functional activities. This is an interesting study collaborated with the main investigator, Professor Su Huanxin in Macau, showing the protective effect of endogenous and exogenous omega-3 on microinfections. By using two photon microscopes, the single arterial occlusion can be induced by the laser damage, and the residue effect by omega-3 can be beautifully visualized in the left lower panel, and the molecular involvement of RIPK1 and the behavioral changes can be demonstrated. With the result of this study, we are now conducting a randomized control trial in depressed patients with microinfarction to see the therapeutic effect of omega-3 fatty acid. To summarize our work and others' work, I propose two applications about how to personalize the use of omega-3 in depression. Firstly, the biological specificity. We demonstrate that omega-3 is effective in inflammation-related depression, such as interferon alpha-induced depression and cardiovascular diseases. We are now conducting trials in chronic pains and obesity. We also applied preclinical models to investigate molecular mechanisms. Another application is safety consideration. We apply omega-3 in children, adolescents, pregnant women who are more sensitive to drugs side effects, or to prevent high-risk population to avoid unnecessary exposure to medication. To help the physician to use omega-3 in clinical practice, I invited the top highly cited researchers to work together in a panel of International Society of Nutritional Psychiatry Research to publish a practice guideline of omega-3 fatty acid in depression treatment. We conducted a Delphi survey and comprehensive literature review for the guideline, which is published in the Psychotherapy and Psychosomatics in 2019. This article is chosen as editor's choice with free access and provides the comprehensive information for treating depression with omega-3 fatty acid. I also want to talk about how clinical practice inspires preclinical research. Though we are now more confident that EPA might be more effective than DHA, but I think EPA might not be the answer, but hopefully leads us to the answer. Why? Firstly, EPA is almost undetectable in the brain. So I think EPA-derived molecules may be more directly to the therapeutic effects. My collaborator, Professor Richard Bazinet from Toronto, published many fantastic work about omega-3 derived mediators. So we started to work together from both clinical and basic sides. This is one of our collaboration to investigate a new target working with Richard. We hypothesized that omega-3 derived endocannabinoid, the ECB, might be important in the treatment of depression. So we randomized 92 eligible major depressive disorder outpatients in a 12-week double-blind clinical trial to compare the clinical outcomes on the left panel and the biological markers on the right before and after EPA, DHA, and EPA-DHA combination intervention. We found that EPA-derived endocannabinoid, the EPEA, seems to be the key marker for EPA's antidepressant effects, meaning EPA works when EPEA levels go up. This is another example to show omega-3 PUFA-derived lipid mediators may be also important. Dr. Borsini used hippocampal progenitor cell lines and found both EPA and DHA prevented the apoptosis and neurogenesis reduction. In her sophisticated experiments, she showed that the effects were mediated by the EPA and DHA lipid mediators metabolized by the lipoxygenase, the LOX, and the cytochrome P450, which we further used major depressive disorder patients in DHA and EPA clinical trials to validate the result. The COVID-19 pandemic changes the world. It's not just the viral invasion to the lung or specific organs or a systemic infection. It's also a whole cycle neuroimmunity model to the brain behavior and immunity. At the beginning of the outbreak in March of 2020, I initiated a special issue about COVID-19 in the Journal of Brain Behavior Immunity. We collected 93 papers in 4 months, which collected huge citation on this issue. Recently, we know that COVID-19 infection could lead to prolonged sequelae of heterogeneous negative impact in multiple systems, known as long COVID. Literally, the scale of chronic inflammation of the long COVID is global and extensive, and I concluded in this new article in Brain Behavior Immunity that omega-3 might have a role in the prevention and intervention for long COVID. Here now, we collaborated with international collaborators and published more than 10 papers on COVID-19. We also collaborate with our neurology colleagues and collaborators from Hsinchu, Kaohsiung, and Taipei, and published more than 10 papers on non-invasive brain stimulation, including RTMS. For several years, I've been conducting 科技部台湾波兰双边合作计划 and published more than 20 papers about genomic and novel biomarkers for medical and psychiatric disorders. Our collaboration with China is also productive. I regularly supervise and work with researchers from Wenzhou, Shanghai, Beijing, Guangzhou, Aumen, and promote the Pacific Asia Society of Psychoneuroimmunity. Finally, we could not have this collaboration and co-publication without the support by 台中附设医院周院长 to our annual My Body Interface International Conferences. 我们已经进到第12届，我们也期待这个国际会议能够像水南校园一样，也让中医大台中能够成为亚太地区身心医学的一个地标。再次感谢周院长的大力支持。I'd like to stop here to acknowledge the founding bodies, my collaborators, and most importantly, my laboratory colleagues. And thank you very much for your attention.